So, the knot tying with Sahar, right?
Hello, yes.
Are you ready, Sahar?
Just a second, let me open the door.
Yeah.
Oh. You guys see?
Yes. Where the knot in depth? I didn't see. Not at depth.
Okay, I'm glad.
Okay, okay. Now let me
Here.
put a timer on 1 minute. Okay, 5 minutes. You can start, Sahar.
Okay. Okay. So what do you want me to perform now?
Just start by reef.
Reef knot, okay. Come back with 3 fingers towards me.
Baba, this stranger.
Hajar, please mute yourself. Batul, please mute yourself.
Okay, these are 3 now. Away, and then come back with the 3 fingers towards me.
All right.
The granny knot is similar, but 2 throws.
Okay,
same
can I
side.
ask you
Sure.
what type of suture material did you use for this reef knot?
I'm sorry, your phone, your voice got cut off. What did you ask? Dr. Mohammed?
What type of the suture material will you use for this reef knot? Continue your procedure, please.
Vicryl, I would use a Vicryl 30.
Becquerel. Okay.
Yeah.
And what other knot do you know rather than reef knot?
So reef knot is also known as the square knot. I know a slip knot, the granny knot, and the surgeon knot.
Okay. You are doing knot on depth or reef?
No, Reef. You told me
Okay.
to continue.
Okay, continue. Yes. Uh,
Yes.
now, what is the vicryl made from and when it is fully absorbed?
So Vicryl is made of polygalactine, and it's fully absorbed between 56 and 70 days.
Mhm.
And it holds tensile strength up to 2 to 3 weeks.
Okay. Could you tell me what is the difference between the surgeon knot and square knot?
Okay, so surgeon knot are two throws or two knots, and you secure it outside, and then you slip it down with your to make a secure knot.
Okay.
And the square knot is two throws, 2.5 hitches or throws. They come across each other and holds better.
Okay. Continue procedure. How many knots you need to make for this reef?
Three to 4 knots.
This is knot number 4.
This is, I think, number 8.
Why? Go to the deep.
You told me to get.
No, no.
Okay.
Okay, go to the deep. I'm really sorry. I just want you to continue while answering the question.
Yeah, three,
No worries.
three are enough. Go to the next.
Okay. So for the deep, I will use a curved artery.
Okay, what's the type of
And
the
be very
suture material?
I will use the proline.
Proline.
Sorry, silk.
Silk. Okay.
No, proline is for the bleeding. Yes.
Okay.
So I will secure the knot outside.
Okay.
And use my finger to guide the knot carefully and do not pull on the tissues. Like this.
Okay. Now, can I ask you what is the difference between the monofilament and braided suture
Muhammad,
material?
Muhammad, when she's doing it, can you mute yourself so she can appear on the camera, please?
Okay.
What did you ask, Dr. Mohammed?
What is the difference between monofilament and braided suture?
So monofilament is it's smoother, and monofilament, of course, from and it has less better tensility, and the bacteria does not it does not hold infection because it is unlike the braided sutures, and they're non-absorbable and absorbable. So examples of non-absorbable monofilament is like proline, and the absorbable like monocrea.
How to protect tissue while tying of depths?
Better visibility, I mean, fixing the light and protecting the adjacent tissue and not pulling, and securing the knot outside and guiding it by the finger while holding the tissue down.
Okay, continue your procedure, please. You did 4th knot or not?
Yeah, this is the 3rd.
Complete the 4 and go into the bleeding part.
Okay. The suture is very short. These are 4.
How about the time, Muhammad? How many minutes do we have?
So by using proline for the bleeding point to secure the bleeding point,
18
I will
seconds.
use a
Okay.
hold the needle towards the site of entry.
I will give
So-
you 30 seconds because you
like
made
this
8 notes
and
in your
hold
riff.
it
Okay, continue.
up in order to create hemostasis
How many
and hold the
notes
bleeding
you need
entry in the
you
vessel
need
or
to
vessel.
do for this bleeding point? How many knots?
6 to 7 knots. For this one, it's only the figure of 8.
For
You mean
this?
how many times you need to hold it? Like not
6 to 7.
how many minutes do you have, Muhammad? I think that's a long time, right?
Yes,
Are you counting?
time up, time finished now. I give her 30 seconds because
Okay.
she makes 8 notes for the riff, not 4.
Okay, let's start the discussion then. Muhammad,
I ask her
Okay,
all
these
questions during
are
the
6.
procedure.
okay. So I didn't ask them. Can you tell me how was it? I just
And discard the sharps after using them.
okay.
Yes, I'm done. This is the bleeding point and at depth and the readings.
Okay, good, Sahar. I didn't attend from the start, so I will wait for Muhammad to comment. Meanwhile,
Hello.
The reef not
Hello?
correctly.
Sahar,
yeah, Muhammad.
very, very good performance. You start by riff note, and I think you did it right. The 2 halves is in the opposite direction, and you answer all questions during the procedure.
She
But I noticed that
she
you
had
stop sometimes during the procedure while I asking you. So try to do the procedure while answering.
Okay.
Regarding the note at depth, you said that you will choose proline series 0, I think. But
No, proline is for the bleeding point.
not at depth.
Not at depth, I said silk.
Not at depth Vicryl, because it is absorbable. All right? Vicryl series
April,
0.
okay.
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 And silicone 0 for the reef.
Silk is for superficial sutures, right?
Yes, and silicone 0 for the reef node.
Yes.
this is the most important stage in your exam, and I think we have a video that I tried to make on the school. I'm not sure if it's clear or no. We
It
are
is.
trying to, yeah, we're trying to make another video, but do you think the video in the school is okay, Sahar?
Yes, it's very good.
Yes, we try to bring the materials for you so you can see them and follow exactly. This is how your station will go through the exam. You will be doing this stuff, and the examiner will ask you questions and questions and questions. try to practice this like 6-7 times and record yourself the same. Okay. Yes. we will demonstrate so many videos for the sutures. I made the note in my way, which is a bit more complicated than the normal way, but you can make the note simple now. The only principle is just to make the note stick. That's all what you need to do. You try to train yourself that your note stick, because if your note didn't stick on the exam, then it's gonna be bad on you.
Yeah.
You've that's for me. I don't have anything to add. You can proceed, Muhammad, to the next. Thank you, Sahar. That's good. I think from what people say, from the rest, you performed well. We're gonna review it anyways when we have the recording later. And I want you to review yourself also. Record yourself while you practice.
Yes,
Okay.
Ali. Tahir, I have two questions regarding the discussion of the not tying. Could you tell me when the krill absorb it? After come days?
Recoil is 56 to 70 days.
Mhm. And how
And
long
the
does it hold the
tensility
tensile
is
strength?
Yeah, it holds tensility up to 2 to 3 weeks.
Okay, excellent. Let us go to the next station, which is airway management according to the
I'm just
advanced
asking all the rest of the group. There's 3 or 4 images in the school. They didn't appear to me now. They were appearing to me earlier. It is the same with you guys or just me now?
It was
The
only
proline, the skill picture,
oh, there was
and there's
only a square that there was an image area, but there's no image, actual image.
oh,
ما في image, yeah.
let me do that now. Okay, Muhammad, you can continue to the next. I will just try to fix this
If
one.
you press on this picture, does that make
No,
it
there is no
appear?
picture, Muhammad. No, there is no picture.
Okay.
I try to see. There's no picture. I think when I put a picture, if I waited like 2-3 days, it will disappear. I don't know why. I need to reboot it back. So I'm gonna. You can.
Ali, you can make it as a screenshot.
Muhammad, the
Oh,
picture was
okay.
already there. I already put the picture before, but I don't see it now. I don't know why.
You download
Excuse
it?
me, Dr. Ali, one question. Just I didn't understand what picture on what view you ask.
What do you mean? Now or yesterday?
No. You're talking about something now. I am from the start.
No.
in the meeting.
Yeah. There's a Broline picture that I couldn't see on the school. I'm aware that we put picture for Broline, we put picture for Silk,
Great.
but I couldn't.
Yes. In the screen. Yes, it doesn't show up in the school. Even 2 days ago. Now I review it now. That's not show up. Yes.
Yeah, I'm gonna fix that now. Whenever
Yes. That's why I didn't understand the question.
whenever you find something like that, let us know so we can fix it very quick.
Dr. Muhammad and Dr. Ali, just to go through the types of sutures. For the reef, we can use silk, right? And
Silicone
at
zero.
depth, silk 1-0, yeah.
Yes.
And at depth, we use Bicryl because it's absorbable.
3-0, yes.
And for the 3-0. And for the bleeding point, we use Proline.
Proline 3-0, yes.
3-0
Just
also.
my
Yes,
advice
and
to
this-
do
and this-
the not at depth at the circle thing, so you can resemble the exam circle object. Okay.
The pull down, yeah. Yes.
Yeah, and so we can make it clear for everyone which one to use. So we created the video according to this order. Okay.
Great.
The next station is airway management, advanced trauma life support. I think Hajri, who will do this station?
In the question, the examiner would ask me, use vibrated non-absorbable, for example, or
This- Why recording stop, Mohammed?
I have poor internet connection, Ali. Sahar,
أيوة دكتور.
regarding
Muhammad,
any station
Muhammad, can you, Muhammad, are you recording now or no?
recording,
Yes.
Okay.
regarding any type of knot tying, which Sharif, the examiner will ask you about the suture material and the different and why you use Vicryl and mid Vicryl, and in the depths will ask you that suture material also at the bleeding point. This is 3 questions in each station.
Okay.
So the next station is Hajir.
Yes. Okay.
Airway management and advanced trauma and support. Are you ready?
Yeah. Is the camera clear?
Yes.
Okay. So should I start?
Let me put a timer. And Ali,
Yes, Muhammad.
follow her steps because I have poor internet connection. I will put a timer for 9 minutes. Okay. Now mute yourself. 9 minutes started.
Should I start? Okay. So first of all, I have this trauma patient. So firstly, I want to call for help. Then I want to expose my patient. I'm starting by
Hajir,
looking.
Hajir.
Yeah.
Hajir.
And so for the unconscious patient, looking for his mouth and seeing any foreign bodies. So then I'm going to feel for his respiration for like 10 seconds. There is no stridor, no wheeze, and no snoring. Now I'm going to apply the upper airway. I want to see if the patient have a suspected to spinal injury or not. If he suspected to spinal injury, then I will do the jaw, only the jaw thrust. I don't know. By doing like that, I lift it up by 2 hands like that. If he had no cervical injury, I will just lift the chin by putting my finger under the mandible and opening his mouth by lifting up. Now I'm going to use an oropharyngeal tube after the cervical stabilization. I will show if it's sizable or not by measuring it, and it should be from at 80 degrees so as to overcome the tongue and not get it to go back to the throat. If this did not work, then I go for tricot for endotracheal intubation. If that did not work, then I will go for the surgical options. Regarding surgical options,
No, before you go to the surgical option, who will do the endotracheal intubation?
It required an expertise when to do it either nasally or orally.
Yeah, by the expert. Who you talking about?
The anesthetic patient, the anesthetic doctor, or my senior.
All right.
Okay. If this did not work, then we are going for the surgical options. If we have complete upper airway obstruction, and it's emergency, I will do needle cricothyrotomy, and I will doing this by pressing the cricothyroid membrane just under the angle of twist by doing this simple procedure without anesthesia.
Okay.
And it's didn't and I have touch for then I direct airway access through the membrane. If it's a long-term airway management, I will fifth strategy. I will apply mask according to the situation. If I need low flow oxygen, then I will do nasal cannula here, and if it's moderate, I do simple mask, and it's I will do venturi mask if I need precase oxygen concentration delivery, and for the maximum concentration delivery, I will use an replace mask.
Okay, what are the 3 primary steps of clinical airway assessment plus patient?
What?
What are the 3 clinical steps?
Looking, thank you, Hiam. Thank you, my patient. I will look, listen, and feel.
Okay, what does the presence of an inspiratory stride will indicate?
It's an upper airway obstruction.
Okay, describe the technique and indication for performing chin lift in airway management.
Okay, I will do that by placing my fingers under the mandible, and then I lift it upward to open the airway. And I should not.
Okay.
I should do it with a patient I suspect they have a spinal injury.
Okay.
Okay.
What are the indications for employing cervical spine immobilization during airway management?
If I suspect a spinal injury, I will do it.
Okay. Explain how to deliver ventilation at the correct rate for an atlas patient after stabilizing the airway.
Yes, I will do rate of 8 to 10 beats per minute every 6 to 8 seconds, and ensure that the chest is rising up and down. It's really breathing.
You should say 8 to 10 liter, not beat. Okay.
Yes.
What criteria determine the need for endotracheal intubation in trauma patient? Okay.
First, the patient must have inability to maintain his airway patency by the simple or basic maneuvers, and he should have, and maybe he have hypoventilation and hypoxia despite my oxygen delivery, or there is significant facial or head trauma, or I anticipate that the period of his recovery will be long.
Yes. And what clinical condition would you consider surgical airway as a primary choice?
Okay, I will go for surgical airway when there is obstruction, like there is edema or there is laryngeal fractures.
Okay. As a primary, do you have any other reason?
What? Rather than fractures of the face, of head, all types of fractures, or inability to go through it, and through intubation.
Okay. How is needle thyroidectomy performed, and in what emergency situation is indicated?
It involves inserting like needle through the cricothyroid membrane to provide an emergency oxygenation for the patient. It's indicated in cases of complete airway obstruction where I cannot do intubation. And in the same time, I need immediate oxygenation.
Okay, in simple terms, can you differentiate between cricothyroidotomy and tracheostomy?
Okay, cricothyroidotomy, it's quick and needing no anesthesia, easy stabbing through the cricothyroid membranes with no anesthesia, and it's life-saving. And the formal tracheostomy, it's not an emergency, and it needs a full anesthetic set, and it's ideal when you need a temporal intubation or permanent intubation. And I will cut the second and third tracheal rings after dividing the isthmus.
Okay. Because I don't.
Yes.
Okay. Fine.
And it happened.
I think that's all. You still have 40 seconds. Anything want to mention?
Yes, I can mention that it's very important to call for help in this situation and have trained team who all know how to deal with such patient, because every second in this patient is critical.
Okay, time finished. All right, good, Hajir. There's just quick point. I think you answered everything. You did everything right. When you go on the station, on our side, it will be written, you have a patient, for example, who presented with airway problems. You need to examine your patient and treat him accordingly. From this scenario, you will understand your patient has a car accident 1 hour ago or 30 minutes ago. From this station, you will understand your patient is ATLS patient. And that you need to measure his airway management. The way you come to the exam, you show your badge, you show your number.
Okay.
They will ask your candidate number. You will say my candidate number is 2121 or whatever. And then you will start immediately talking to your patient. Hello, Mr. John. Hello, Mr. John. My name is Sahar. I'm one of the surgical doctors working here. Can you hear me? Can you nod your head for me? It will be a plastic. It will be market. The examiner will tell you no. There's no any response. Okay, Mr. John, I will be your doctor today. Okay, firstly, I will have a look at your breathing now. I will put you explain to the market what you are doing. I think you just need the start to get it right. I will come and I will ask for help. No. And then you immediately, when you notice there's no air entry, you stand up, you say, hi, hello, I want some help here. I want some help here. Then the examiner may stand up and come with you. Do you understand the entrance of the station?
Yes,
It has
I
a lot
do.
of acting from your side. It has a lot of acting from your side.
Okay.
You come in, you come in, you expect your patient to talk to you, but the patient will not talk to you. The examiner will tell you the patient is not talking. Then you will tell them, you're still gonna communicate to the patient. Okay, Mr. John, I just want to make sure your breathing is fine. I'm gonna come closer to you. You come closer to his nose or face. You check there's no any respiration. Then you immediately stand up, scream, I need some help here. I need some help here. You wanna collect people, and then you do what you did now. Do you understand that?
Okay. Yes, I get the point. Yes.
Yes.
I
So when
should
you
make
practice,
it like a real, like,
yes, like you are in the emergency trauma, and you have a patient who is suffocating,
yes.
doesn't breathe, and you never
Yes,
speak
yes.
to the examiner saying, "I will do that," or "I will do that," or "I will measure that." You wanna
Okay.
measure it, you measure it. You take it, you say, "Okay, I'm gonna measure that one." And on the exam station, they may show you this. That's why we put a picture in the school at the end. They may show you each of these, what they call it, adjuvant of the airway. They may be there, so you're gonna use them to measure. You're gonna use them to measure them on the patient face. Okay.
Yes.
Hajir? Hello.
He will not argue with you about the size.
Okay.
It's
Hello.
not human. You cannot really measure it.
Okay. I
Hajir,
have thing to add that. Yes, Dr. Mohammed.
I lose my internet connection. Your performance
No.
was very good. I just wanna to mention about what Ali Boyne mentioned, which is act as this is a really patient. We need to look for
Yes, yes.
the chest from any side and the cervical vertebrae. And when listening to the patient all feel, you can put your ear beside his mouth while looking to his chest movement. Okay.
I have a question. Dr. Mohammed.
Okay.
Ali.
Yes. Immediately ask your question.
Yes, right. But to feel the breath, should we يعني نكتفي be only putting the fingers against the nostrils, or we should keep our cheeks to feel for the breaths for 10
Okay,
seconds?
that's your patient, okay? Like this way. You
Yeah.
come here like this. You come to your patient, like what you do in the A&E. You really come close, you make sure you hear any breath while, as Muhammad said, while you taking to the chest. That's how you do it.
Okay.
Well, another question, Dr. Ali, if you don't mind.
Yeah.
About the ATLS, I don't know. They said that when they start, if the patient in the street, they said, make the sense. Patient now is in the hospital. No need to say
Yeah.
to the examiner, the sense is clear. Am I right? Or just correct me if I'm wrong.
You are totally right. You are totally right. I'm glad you mentioned that point.
Make the sense clear, say if the patient is safe, but I am not confused. You are talking about the patient in the hospital, in front of examiner, or in the street.
From logical point, there's no need to make sure the space is safe, but you will lose nothing. You will lose nothing by saying, I just want to make sure this place is safe for my patient, even if he's in the hospital. And basically, I'm going to just add it now to school to make sure that you know it. So it doesn't make sense to ask if the patient is, if the place is safe or not, but you need to ask just in case your examiner is very like what the word, your examiner is very picky. Maybe your examiner will be very picky and he wants to hear that one. Okay, so we'll ask. I'm updating school now. Ask, is the scene safe? Usually your examiner will say yes. Do you understand?
Yeah.
Your examiner will say yes.
Yes.
Then you're gonna proceed with what we say. Okay?
Okay, Dr. Ali, I just have something to add.
Yeah.
That oropharyngeal and nasopharyngeal tube, when there is in or off gag reflex, should we mention that? As if the patient has.
No, the examiner will ask you what the examiner may ask you what the difference and when to use which.
Yes.
Yeah, and I think Hajar, we have a question on the school on this regard, right?
I don't think so.
Let me just check. Let me just add these questions. So you will scream and ask for it. The difference you said between oropharyngeal and tracheopharyngeal, right?
Yes, and when to use it, if there is gag reflex or not. Our patient is fully conscious or not conscious.
Yeah. Oropharyngeal airway.
The perfect
Okay, I'm
answer
just-
for this differentiation between the nasopharyngeal and oropharyngeal,
Yeah.
basal skull fracture, which you use oropharyngeal rather than the nasopharyngeal, because nasopharyngeal here is contraindication for the basal skull fracture. The most,
Nasopharyngeal.
yes, this is the most point in this differentiation.
Yes, you're totally right. Yes. No, yes, contraindication, even to introduce NG tube in the skull base fracture. You're totally
Yes.
right. Yes.
Basal skull. Okay, so Hajar, The nasopharyngeal is
Yes.
obsolete. We never use it in a basal skull fracture. And you added
Yes.
another point. Remind me what's your point. If there is a gag reflex, we don't
Gag
use
reflex.
oropharyngeal.
Yes.
Yeah.
I think we
Okay.
finished today, Ali.
Yeah, all updated on the school. I just want everyone to have a look, just to make sure everything is right. If it does need more care, send a message. I think it's perfect now at the moment with all the questions. Yeah, Mohammed, we finished today. It's not gonna be a long session. We have a session the day after, right?
I think tomorrow.
I
When
have
our
one
tomorrow.
question. Yes, Dr. Ali. No comment.
Yes. Not tomorrow,
Please don't.
Muhammad. 13.
Sorry.
Yeah.
Sorry.
Say, Muhammad. Yeah, I'm listening.
Okay. For me. Oh,
Yes.
please don't forget the lecture of vascular.
Oh,
So you-
the lecture of vascular. Yes,
Regarding
yes,
PDF, you said
ischemia.
something you want to send it. I think you are busy. You didn't send it. This is
Oh.
number one. And number two, I have noticed that in urinary catheterization, if there you said there is some kind of abbreviation. I didn't know what do you mean by it. When you if there is no urine comes after flushing and that you have to remove IC. What do you mean by IC? I don't know. I have seen it in the school. I
Indwelling
didn't know.
catheter.
Okay. Yes, because I didn't
Muhammad,
understand
please.
what.
Yeah. You are totally right. It's very confusing, to be honest. Even me now, I forgot what IC means. Let me just
Yes,
change
please
this.
write it in the school. Yes, so that to explain more.
Yeah, let me just. So this was on which one? Urinary catheter. And why was IC? Let me just put in now so nobody's confused. Did you remember the line? On which line was it? Yeah. I found it now.
We really sorry about this abbreviation, Mr. Muhammad.
Indwelling catheter. Yeah. Updated Muhammad Kamal. Thank you for that. Okay, everyone, see you tomorrow. Muhammad, I'm gonna call you now on your phone, okay?
Okay.
Bye.
Goodbye, guys.